Good afternoon. My name is Indira Bonner. My pronouns are she, her. I serve as the Associate Vice President for the Equity and Justice Center of Excellence here at the YMCA of Greater Seattle. Welcome to the YMCA of Greater Seattle's community conversation entitled Creating Sustainable Health Equity in Washington. Before moving forward, I would like to acknowledge, on behalf of the Equity and Justice Center of Excellence, that the YMCA of Seattle's branch locations, education, and campsites reside on the stolen lands of the Coast Salish peoples. As we work, live, and play on these territories, we must keep in mind the ongoing effects of colonization, communities of struggle for self-determination, colonial state violence, and recognition of Indigenous sovereignty. Bell Hooks in Killing Race, Ending Racism shares, there must exist a paradigm, a practical model for social change that includes an understanding of ways to transform consciousness that are linked to efforts to transform structures. As human beings, healthcare is basic, essential to our very existence. It is for this reason that the transformation of consciousness is about how we engage in sustainable, racially and intersectionally equitable healthcare practices. We must redesign the institutions that provide our healthcare to center those most impacted by marginalized identities to address the multiple other systems that create continued negative and traumatic outcomes for many of our communities, generation after generation. Healthcare provision is a massive set of intertwining systems. So when we think about this conversation, the intent was to show a small representation of how a topic like healthcare affects communities in varying ways, and to show how to look at health equity solutions from a multifaceted lens. We will focus on 3 communities in this conversation: the Black community, Latinx community, and Asian community, highlighting 3 different areas of healthcare and healthcare provision. Welcome to our sacred space. We are honored to learn together as a collective. During the program, please direct your questions to the Q&A chat. So that's the box down at the bottom. This is Q&A. We will answer the questions with our moderator and panelists during the Q&A panel time. There's a quick access note that we would like to share. This access note shows the silhouettes of people who have different body shapes and sizes. They're moving, lying, or sitting in many different configurations. Some have mobility equipment. One has a service dog. One is pushing a baby in a stroller. My favorite one is the person who's lying horizontally flat on the ground. That person actively speaks to my feelings of emotions sometimes. Use this space that you're in as comfortably as possible for your mind, body, thinking about what you have carried or brought to you with you in this space. Now I'd like to introduce our moderator for today, Rahel Schwartz. Rahel received her BA from Harding University, Arkansas in biology and chemistry, and has an MPH from Walden University in Minneapolis, Minnesota, with an emphasis in community health education and promotion. She currently works as our program executive of health equity here at the YMCA of Greater Seattle. Rahel has 15 years of experience in program development, behavioral health coaching, and works as a fitness instructor. I do recommend taking Rahel's class. She's amazing. And in community mobilization with diverse populations. Rahel is also the co-chair for the Ethiopian Community Health Board. She's a consultant for Health Equity Community Advisory Council at Seattle Children's Center for Diversity and Health Equity. She serves as a community consultative group member. She is with the IRB committee at Fred Hutch, and she's a community advisory board member with Harborview Injury Prevention and Research Center at the University of Washington. Pretty much all around one of the most amazing people you'll ever meet. So now I would like to have you join me in welcoming our moderator, Rahel.
Thank you, Indira, for the wonderful introduction. Thank you, everyone, for coming, and especially for our panelists. Welcome again to the Health Equity Y Community Conversation entitled Creating Sustainable Health Equity in Washington State. Today's Y Community Conversations will help us increase knowledge on how to use an intersectional race equity lens to address health disparities and center community in problem solving and solutions. It would also address disparities in Asian American or Asian elder healthcare, HIV/AIDS care in Black, African American communities, and Latinx, Latin American, Hispanic healthcare resources needs for prenatal and postnatal care. This community conversation will share ways in which racial equitable systems can redesign themselves to effectively support, nourish, and create beautiful spaces for those with healthcare needs to thrive. Before we jump into the conversation, let me take a moment and introduce our guest panelists for this afternoon. I am excited to welcome Louis Shackelford, External Relations Project Manager, HVTN, co-VPN at Fred Hutch. G. D. Castro, Director of Aging and Adult Services, Asian Counseling and Referral Services. Betty Hernandez, Lead Latinx Community Specialist, Birth Doula Services. Last but not least, Dr. Tumani Cocker, Chief of the Division of General Pediatrics and Professor of Pediatrics at the University of Washington School of Medicine and Seattle's Children. Thank you all for joining us. Now let's get to know our panelists a little better. We would like to provide space for each panelist to introduce themselves, the role they serve in, preferred pronouns, and to share the work they are doing. So we will start with Louis.
Hello, everyone, and thank you, Rahel. It's really great to be a part of this space. As stated, my name is Louis Shackelford, he, him pronouns, and I am an external relations project manager at the HIV Vaccine Trials Network. So my role really focuses on raising awareness, building knowledge and education around, and involvement in HIV vaccine clinical trials. So I have been involved in many different capacities in HIV research, specifically community engagement in HIV research for nearly 14 years now. And I'm really happy to share my insights into this work and community engagement in this space. I will also say that I also serve as a member of the UW, University of Washington, CFAR Community Consultative Group with Rahel. And so I'm so happy to see her in this space and be a part of this event today.
Thank you so much, Louis, for being here. Next, let's go with Tumani, Dr. Coker.
All right. Hello, everyone. It's great to be here, and thank you, Rahel, for serving as our host and moderator. So I'm Tumani Coker. I am a professor of pediatrics at the University of Washington. I'm a general pediatrician by training, and I work clinically at Odessa Brown Children's Clinic, where I work with the trainees, pediatricians in training there. I also serve as division chief for general pediatrics at the University of Washington in Seattle Children's, which is a division that focuses on primary care pediatrics practice. I spend most of my time as a health equity researcher. So in my research, I partner with community clinics, and we've been working with various community clinics, both here in Washington State, Los Angeles, California, on how do we make sure that families receive the kind of care that they need particularly during the early childhood period in primary care, to make sure that they have the ability to promote the best possible potential for that child and their family. So we have been working for over a decade now on how to integrate community health workers in particular into primary care services for community clinics that serve families primarily who are Medicaid insured or publicly insured families. So that's my research. In terms of the education at University of Washington and Seattle Children's, I co-direct a fellowship program, which is a training program for health equity researchers who are going to focus on child health. And I think, as we saw in that video that was played earlier, we have a long way to go in our healthcare system. And so part of that is training the next generation of folks who are going to be doing research as well as practice in providing equitable care. So I'll leave it there, and I look forward to our conversation.
Thank you, Tamani. Let's go with Betty Hernandez.
Thank you. Yes, my name is Betty Hernandez. I'm using she, her, ellos as pronouns. I'm an immigrant, indigenous Mexican. I'm the Latinx community specialist for the birth doula services program at Open Arms. And also I'm birth doula, lactation support. I'm coordinator of a parenting group for the Spanish-speaking families. I have some background in OBGYN nurse, and my role in the community is to be a bridge, providing information, resources with the community. And also my passion is around social justice. I'm doing some organizing work and kind of providing some support in the community. And my particular role at Open Arms is providing doulas for families that cannot afford it for that doula care. And we try to create culturally, if we can, be able to provide culturally based or community-based doula for that family, then it can be with them during this period of the perinatal. Sometimes we support immigrants, we support families that are going through one domestic violence program, or just they move to the United States and they need a lot of resources to be in a safe place for them and for their family, and just to support the families to reduce the stress that can cause that big impact during this area. We provide this doula care for everyone who will be eligible for get this as a free.
Thank you, Betty, for the introduction. Last but not least, G. De Castro.
Good afternoon, everyone. Thank you for inviting me into the conversation. I'm G. De Castro. My pronouns are he and him, and I currently serve as the Deputy Director of Asian Counseling and Referral Service, ACRS. We're a nonprofit social justice organization based in Seattle, and we provide health and social services, a wide array of programs to the community, primarily focused on Asian, Native Hawaiian, and Pacific Islander communities in King County, primarily, but also Snohomish and Pierce, and to a certain extent to the wider Washington state. I'm participating in this conversation because prior to my role, until recently, I was serving as the director of our Aging and Adult Services program. And in that capacity and in those programs that ACERS provided, we're a partner with the City of Seattle Aging and Disability Services, who is also our area agency on aging for King County. So we have several programs that we, as a provider for the City of Seattle ADS, that include our senior center, our senior congregate meal program, our Title 19 case management program for Medicaid eligible clients needing care at home. And we're also, ACERS is also part of the King County Integrated Care Network on the side of our behavioral health recovery services programs and services. Yeah, I think I'll leave it there for now so we can get on with the conversations that we're gonna, I look forward to learning from everyone today. Thank you.
Thank you so much. And I would like to say thank you all for the panelists for the great work that you do to address, health inequities in serving populations who are disproportionately impacted. Now let's shift to come to some specific questions that will enable us to understand both the urgency and opportunities inherent in seeing the issues through an intersectional and equity lenses. So my first question is, in this community conversation, we're looking at health equity. So health equity means different for different people. And my first question to you is, can you please explain what the word health equity mean? And anyone can go first, or I can go.
I can get us started. So for me, I come at it, I think, from the perspective of a pediatrician, because that's kind of how I think I come to a lot of things in terms of health equity. But for me, health equity is giving every family, a child does not exist without the caregivers, a family that supports them. Every family has a different set of needs for them to reach their full potential in health and wellness. And that's in their full potential now, and that's as that child develops and grows into adulthood. So what that means for our healthcare system, it can be very, it's never equal, right? And so I think when I hear that, like, oh, well, if we're going to provide this services to this, segment or this family, we have to, it's every family needs something different. And so there are, particularly when we're working with families who have low incomes, for example, they are going to come to our visit, right? That office visit, that well child care visit or a preventive care visit with a whole range of needs that may be another family where income is not a problem, for them. And that means that my visit has to be different, because health equity is about, okay, what do you need to reach your full potential, which is going to be different across different families. And so I think that's some of the work that we've done in recognizing that many times in our healthcare system, our services are designed for is designed for people who have more resources, who are more highly educated, who don't have the experiences of structural racism, who speak English, and we can go on, who it's designed for, but it's generally not designed for those folks who who experience structural racism in its many forms and whose families have done that, which means that it is not equitable yet. So to get to equity, we have to figure out, okay, let's redesign everything from the beginning. What do these family needs in terms of a healthcare system? And that's how we get to equity from my perspective.
Thank you, Dr. Cocker. Who would like to answer the next?
Yeah, I would like to say I agree. I think health equity is everyone having the same opportunity to be healthy or to be their healthiest selves. And so when you talk about health equity, you have to talk about things like access. You have to talk about things like resources. You have to talk about all of those things mentioned by Dr. Croker. And you have to also talk about, I think, who is prioritized by the systems that we live within. And I think it's inherent that some people are prioritized and some people are not. And so I know that we'll probably get into that more throughout this conversation, but I think that's a critical component because we see that some of the issues that we have in health equity are based off of not the fact that resources aren't available, not the fact that there's not access, but sometimes it's just certain people are being prioritized by the system and certain people are not.
Thank you, Lois. Betty, or?
Yeah, thank you. I think you cover clear this concept, and I agree with you. So I've been thinking about what the Global Health Organization says, and they say that the health it should be a fundamental human right, but we can see in our society that this is not what reflects the health system. We can see a lot of inequities, and I like how you describe about so we can if we are thinking about providing equal health for everyone, we have to go in a deep look for individuals. So, and because we can, when we break down for individuals, and we saw that unfortunately we have a lot of segregating groups, like they are not receiving the same health care than someone could have better economic or social, or lives in a better demographic area. And also when we saw this disseminations, we can see that it also will be impacted about the sex, the gender, the ethnicity. If we don't speak the English, we cannot be able to understand, but also the system sometimes are translating things. I've been thinking about Spanish, is translating everything in Spanish, but the community who speaks Spanish are coming from different regions, are coming from different culturally, from different understanding. So I think it's important to so wide that wide umbrella, and not just putting in a box communities and serving them with the same in the same way. We have to go deep in the community and see exactly what is the need and how we can provide that care to that can be able to use it the community, but also as health system, we can be successful providing the right care for everyone.
Thank you, Betty. Would like to add G or answer?
Oh, I think the other panelists have articulated what I would have shared. I will only add that, you know, ACRS, our organization, is currently celebrating our 50 years of in existence, and that means that we're talking about health equity today. ACRS was born out of a need for culturally, linguistically appropriate services, behavioral health services to begin with. Back in the early 70s, you know, the medical director of, or the behavioral health director of the Harborview Clinic at that time was looking around and not seeing Asian people coming into the clinic. And that didn't mean that Asian people didn't have mental health needs. It's just they weren't coming there. And sort of that kind of was the impetus for asking the question of like, how do we reach out to our community members who are not receiving these services, not because they don't need it, but probably they don't know how to access it, or yeah, they don't know that it's here, you know. So those kinds of questions that we're trying to answer today have been in existence for quite a while, and organizations like ACRS and similar community-based organizations exist because of that recognition that, you know, we still have quite a ways to go as far as health equity for, you know, we talk about health, not just physical health, but mental health and all the aspects of health and wellness that hopefully we'll have a chance to cover today. So thank you.
Thank you for your response, all of you. And in our at YGS, our role is, you know, recognizing, you know, our community's needs and addressing them, their social and health needs based on each population, each community. Each community is different. We each, even within one population, we have, you know, different languages, traditions, values. So valuing that and creating opportunities for populations and tailoring our programs and services and assisting our populations to navigate those resources are critical in all in what we do. We're gonna, my second question is, each of you work with communities, with different community or different populations. At this panel, we took the approach of looking at one issue from many lenses to highlight culturally specific needs and to find the threads that bind our work together as a collective. Can you please highlight one or two barriers the community you serve face? So we can start with Louis.
Always willing to get the party started. So I was thinking about this question, and I think two things for me. One of them I already mentioned is prioritization. You know, we have a lot of tools in HIV research, in HIV in general, but those tools are not distributed in an equitable manner. And so we know that PrEP access, for example, overwhelmingly the majority of PrEP prescriptions are given to white people, particularly white gay or white queer folks. And so, but we know that HIV has a disproportionate impact on Black queer folks and Latinx queer folks and other people of color like Native queer folks. So there's a disparity there, and that disparity isn't just access. I feel like we focus on access a little bit more than we should. I think it's really about being prioritized and how we message things and how we get the word out and how we deliver services to people and meeting them where they are. And those are things that we don't necessarily do for our communities of color in the same way that we do for communities that are not of color. So that's one thing, is prioritization. The other thing is dehumanization, and I'll use a big word, infantilization, which just means to make somebody seem immature or seem almost childlike, in the sense that you can't handle your own affairs because you're not mature enough to handle your affairs, so I need to handle them for you. And so I think that comes up a lot in HIV spaces, because we, particularly in research spaces, because we have researchers from very, very well-known academic institutions that don't see community members as their equals. And that could be because of education, that could be because of class, that could be because of some sense of ability, knowledge, skill level. There's a whole host of reasons, but this divide between academia and community is really a barrier, and it leads to community members being looked down upon, being looked as, people that need to have something done to them, as opposed to being full members or partners in the work that is being done. And that's a real shame, because when we are all full partners in the work that we have done, particularly work that is designed to increase our health and well-being, we all benefit. And we have more robust programs, we have more robust solutions when we're all equal partners. But when that doesn't happen, you have things being done on one community, instead of with a community or with a person, you have things being done to that person. And that doesn't always hit the mark. And we know that because we still have high rates of HIV infections in so many communities of color, as I mentioned before. So I am always disheartened that these things still exist, but I'm always encouraged that these are things that we can address if we really put our mind and focus on them.
Thank you, Louis. I think creating a bi-directional relationship between clinicians and communities are a critical part of addressing health equity. I appreciate that. Who would like to go next to answer that question?
I just want to, what Louis said, I mean, that's so important, I think, particularly from a research perspective. And Rahel, you know, that's one of my passions, is how do we do a better job from the academic perspective, the old ivory tower, so to speak, the academy, on just changing the way we think about research, because research can really be so important to communities who have been left out. But if we can really shift our thinking to community engagement, community-based, participatory, all these things, I agree. I think we need to do that in so many different areas of research. I would say all of them actually need to have some community engagement, whether you're doing all the way from bench to health services kind of research in the community. So yes, and I'll add a few things. I think some other barriers I was thinking about, two big ones are, one I'll start with from a child health perspective, and this goes for adults as well, but from a health system perspective, so many particularly for children, when we're really focused on like, how do we give them all the tools they need to develop into the, their best potential. So many of the things that we need that impact health are actually outside of the healthcare system, but they impact health. And so, I think over the last, at least in my training, I've seen a complete 180 in the way we think about how we addressed what we now call social determinants of health, right? But really, like, people's lives is what it is. And so if we have a family coming in and they've, let's say we're dealing with anywhere from asthma or to depression, all of those things are going to have need some intervention that as a health system, we need to have these connections with community to be able to solve, right? So the solutions are not always going to be in that provider room at the clinic. The solutions are so often in the community, but we're so siloed from community that it makes it hard to really, it doesn't make it hard, it's not an effective or efficient way to really impact health. So that's one big barrier, I think, is our silos, right? That we have historically thought about health as medical, and the other part of health is all outside, but it's all the same thing. We need to be working together. And then the other thing, I think it's kind of similar to what was talked about in terms of the relationships on the research perspective, from like investigators and academia and community members who are the ones who should be deciding how things get rolled out and how things get studied in their community. And those same relationships are important for your provider, right? So for the clinician and the family, or the older adult or the teenager and so forth. And for our underserved and oppressed communities, that relationship, for so many reasons, is strained because of racism, because of classism, because of historical and current issues. And so if we really want to be, and I think that's one area where I've been thinking, how do we bring in other people as part of the healthcare team that can have that relationship with the family and bridge that gap, both in the relationship, but then in that connection with the community too.
Thank you, Tamani. Betty or G, would you like to add?
Thank you. Thank you. Yeah, I think Dr. Tamani brought a lot of characteristics that impact the community with how the health care system is providing the care. And something that really make me think about also what we are doing when we saw the rates about the infant mortality rates in the area. When we saw when we divided from ethnicities and racial categories, we can see clear that the Black birthing people are dying 3 to 4 times more than the white people in this. So I think we can see clear from where it's coming. It's coming from the racism. It's coming from the classism. It's coming from the mistreat about information, how we are presented the information, how we are presenting the care to the communities. We are not really engaged with communities. We are not really see individuals in our communities. And when I've been thinking about immigrants or Latinx community, so there are over 11 millions undocumented immigrants that they are not able to have the coverage from insurance or getting services. And even if they are a part of this work force in the country, they are not receiving the care that other communities are receiving. And sometimes it's not because they are not able to do it, just sometimes they are not able to receive that information and how can get that access. And so from there, we still have to do more advocacy and more more education to the community. And if someone equal from the same community is providing that care, that information can build that trust in the system and can change that outcome. But if the information still coming from the supremacy, from the right thing to do or act, so we will still be thinking about that we are not fitting in that system, because that system, it's not doesn't have the shape that we are in this as a part of the community.
Thank you, Betty. Appreciate the response. G, do you have anything to add?
I would go back to the when I think about the question, going back to the lived experiences of the communities that we serve, you know, particularly our elders and seniors in the Asian community, who many refugees and immigrants coming from developing countries whose systems of healthcare and social services aren't as developed as the United States, you know. So even though it's here, I mean, I see some comments here about cost being definitely one of the issues for access. Even if there were services that were attainable and cost was not an issue, because the lived experiences of the people that we serve, they don't have these kinds of systems in their home countries. There's just not that awareness or an understanding of what good these system might provide for them. And so that's part of what our organization and many organizations, you know, the education piece, the outreach piece of what is out there that will help you live healthier lives. And the other piece is something more basic, is the language piece of accessing, you know, these resources. For us, you know, English speakers, it's sometimes already complicated to understand how to get into these resources and access them. And, you know, so you can just imagine for folks whose language is not English, or they're not proficient in speaking English, trying to get access to these resources definitely is a barrier. Yes, you know, I think we're getting better at getting translations out of, you know, publications and documents and all that. But the systems themselves are really complicated, even for us who grew up with them, who know about them. Trying to navigate them is just, you know, can be a bear, and it's very intimidating for many of the people that we serve. Even though it's there, even though we tell them it's free, it's just, it can be daunting for people who don't know, you know, how to get there. Is the big piece of what we try to accompany the communities that we serve. So I'll just add that. Thank you.
Thank you, G. You know, a lot of times working with different populations, you know, disproportionately impacted by different health issues, is not always about the message. A lot of times is the messenger. And also relationship is everything. And you know, because relationship build trust. And when populations, communities trust the messenger, then they are open to whatever we are bringing them. And health literacy is also a big challenge in a lot of the communities, and navigating the system, like you say, G and Tamani, and you know, all of you, is frightening for a lot of people, and people don't even know what services and are available to them. So I am, you know, these are, like, you know, important points that you have stated. My second question is, can you highlight a common thread that health equity work faces across all communities who face obstacles to healthcare, such as poverty, discrimination, and access to critical systems? Louis, you can take this one first.
Always happy to get the party started. Adequate representation of marginalized communities and identities, one that comes up for me. There's a question in the Q&A about what organizations such as the YMCA can do for to increase health equity. When I think about organizations and what they can do to increase health equity or equity in general, I think about representation. You know, if you are devoted to equity in any form, the first place I look to determine your commitment is not in your commitment statement. It's simply in the leadership of your organization, you know, particularly top level leaders and who's represented there. And so if you have an organization that's supposed to be committed to equity, but is not diverse in any shape, form, or fashion, then that tells me that your commitment is not really true, you know, for lack of a better term, that maybe you want to serve a community, but I don't know if serving that community is genuine. I don't know if serving that community is advantageous for where you are in your positionality as an organization at the moment, and that as priorities shift, that the communities that you serve will shift. So I really, to see a true commitment, to see where true value is, I always look at representations within organizations. I think starting there, starting with who's doing the work, who's allowed the opportunity to do the work. We see this in clinical trials over and over again across the globe, not just here in the United States, but we see that most clinical trials are implemented by people from the ivory tower, particularly people who have access to the ivory tower, which are typically white, cisgender people. And so we have places where studies are constantly going on, like all parts of Africa, particularly those that are heavily impacted by HIV. And the only people that these communities see coming to help them are white people. And that has an effect. That has an effect on their psyche. That has an effect when they see me as an African-American man coming in and helping them. They think something different about me and my willingness to help them than they do about this white person, because they're used to seeing white people come in. They're used to seeing the white savior swooping in to do this work. And they think that they may think communities like mine in the United States don't care as much. And that is heartbreaking to me, because we don't acknowledge that while there are certain there are systems of oppression that keep so much. There are so many systems of oppression, and some of those systems, they operate here in the United States differently than they operate in the international parts of the world, or the globe, across the globe, I should say. And just those dynamics alone and the issues that they create like that is just heartbreaking to me. So we always have to keep representation on the forefront. We always have to make sure that there is equal opportunity if there's going to be equality and equity.
Thank you, Louis. Betty, Tamani, or G, would you like to add?
Yes, yeah, I think yeah, adequate transportation in our neighborhoods. So I can see equal opportunities for everyone if we saw those in our community as the facilities. So access to the facilities in an easy way, so everyone can be able to go to the library, to go to the medical facilities, or access to the groceries. But if we don't have that adequate if we don't have that access, we cannot be able to get at in a equal health. Sorry, I have this one.
G, do you have anything to add?
I just go back to what I mentioned earlier about people's lived experiences, and in the same way that ASRS and similar organizations, kind of, we need to listen to what the people we're trying to serve need, and not assume we know what they need, or that because a certain group of people need it this way, that this group of people will need it the same way. Again, that's part of the whole equity piece that we are talking about. And different groups will have different needs, and even if they do have the same needs, the way to get to this same outcome will be different ways. And I think that it's more work, it's more challenging, and that's why, sometimes I think naturally we want to try to simplify things, but it's not, the solutions are not simple. And if we find it too daunting, people might back out or back off from trying to engage possible solutions that might actually be the one we need, to respond to the needs of the community. So I'll share that.
Thank you so much. We only have about 5 minutes for Q&A. We should schedule about 2 hours for this type of conversation, because it's always, we never get through answering the questions. Are there, let me see if we have any in the Q&A. Maybe if you guys can take like 30 seconds or so, if you can share ideas on how health systems can increase equity In our work, we want to increase the awareness of providers in those systems about the lived experience of communities impacted by race-based disparities. I know it cannot be answered in 1 minute, but since we don't have a lot of times, maybe one or two of you can address that.
I could just quickly say one thing, and I think it's, I put this in the answer. It's like, who do you have at the table? And so if you don't have anybody from those communities at the table, either on your staff, on your team, in your advisory boards, whatever it is, in every place, you have to include those individuals. Otherwise, I don't think you can do it. I don't think we get to equity with the current, in the typical way of it being exclusionary. So we have to figure out a way to do that. And I think when we talk about providers, like medical providers, where it's kind of a long haul, but there are so many different ways that we can be inclusive of other folks in the community who have so much to offer, things like bringing doulas, and as Betty described, that can be really important as a part of the provider team. So we have to expand the team, and I think we have to include those folks on the team.
Thank you, Tamani.
Thank you. Yeah, I want to add just a little about this. Yeah, including doulas, just to change the outcome during the birth and delivery and during the whole perinatal area. But also something else that I've been thinking about for the Latino community will be including promotoras, leaders who can go and come from the community and educate and link people to receive their resources. And because the promotoras could be have that qualification of bringing data so we can support the particular needs from the community, and at the same point, so the community will be responding, it will be changing the health outcome.
Thank you so much. I believe that in our work to address health inequity, I think the critical, the most important factor is for all of us to come together and be able to serve the communities, the populations that we serve, and by tailoring what we provide and address their whole person health, their social and health needs. That could all be done when we are intentional, and also when we have representation, and when we show our community members that they are 50% responsible for what we're trying to do. It's not to do to them, but to do with them, and not always seek their guidance as we are all working to service our population. Thank you for being with us here today. I really do appreciate each of you. I have the honor of working with a couple of you. So in these spaces, so it makes me happy that when we come together and have the opportunity to talk, and also see opportunities where we can work together as we move forward. The problems are so much, and it requires all of us to come together. And for all of you who attended this this conversation, we hope this has been meaningful. We invite you to share your feedback with us using the link that is being shared in the chat box. We would love it if you could think of one word or a quote which really resonated with you about today's conversation, and share that in the chat box also. We invite you to explore our resources shared in today's PowerPoint. We will share a recorded copy of this video along with the resources from the PowerPoint slides with all that attended or registered for this community conversation. We invite you to our future Y community events in June 2023 as we explore joy in cultural and community connections. Our Heritage Month offerings are free and open to all. Thank you so much for joining us this afternoon, and have a wonderful, wonderful weekend. Thank you all.